I would like to introduce Prasanna de Silva, Moon Vermont Hospital, Switzerland, United Kingdom, and the topic will be medical aspects of COVID-19 lessons for clinicians.
Okay, can you hear me?
Okay, could you?
Yeah.
Okay, I can't access my files, and I've just got into trouble in terms of accessing Zoom. Best laid plans, eh? I'm just wondering whether I can just talk to my slides.
Okay, I will be
if that's all right.
Yeah, that
I
will
don't know
be fine.
why I can't get into Zoom. Just do my best. I don't know why. Here we are. Here we are. Sorry. No, then. Oops. I'm just wondering whether I should start and just speak to my slides. I'm not going to go through chapter and verse of my slides. I'm just going to touch on what the audience would like to know about COVID-19 and the lessons we have learned from the first wave, if that's okay. Can people still hear me all right?
Yeah, we can hear you.
Okay. So COVID-19, we have just been through the first wave, and the doctors and nurses, particularly in the States and Britain, are trying to come to terms with what has happened, but also to learn lessons from the virus. And my kind of take-home message is the virus has taught us a lot about what we normally do, which is managing communicable diseases. The previous speaker spoke about imbalances in energy. It's a notion in Chinese medicine. It's not just in Chinese medicine, it's also in Ayurveda, which is the Asian medical practice. And in the West, I think we have now starting to realize that the problem is imbalances in our immune system. That seems to be the biggest issue. And there are slides in my slide pack talking about the adaptive immune system, which is T helper cells going down an inflammatory path or non-inflammatory path, versus the innate system, which is your macrophages and all that. And basically, there are about 6 parameters. The body does a fantastic job normally in keeping these in balance. And of course, what has happened during the COVID infection is that the balance has been lost, and there's evidence of immune dysregulation, which is what we have learned about. Okay. The other thing I suppose we have learned about is toxins, which are not good for the body, which causes a group of chemicals called reactive oxygen species, ROS. And these can be caused by a number of reasons. The first thing which people around the world, particularly in big cities, are aware of is air pollution. And in particular, this thing called microparticles and nitrogen dioxide, which both increase the accumulation of ROS in cells. And the other big thing is diet. And the toxic element of diet is fructose, this half of sugar. And as you know, around the world, sugar manufacturers and confectionery and processed food manufacturers are changing from adding in sugar to adding in fructose through this stuff called high fructose corn syrup. And those are the two main kind of toxic factors for accumulating reactive oxygen species. As it happens, the virus COVID itself can cause accumulation of ROS. That is by getting into endothelial cells and causing this stuff called angiotensin 1, and that causes leads to reactive oxygen species. So essentially what I'm saying is the main lesson from COVID phase 1 has been that that we have a better understanding of non-communicable diseases as a consequence of this virus, which I guess is quite good news, that we have a better understanding of what ails us in the West, and also, you know, in other so-called developed or developing countries. It is this stuff called reactive oxygen species, which is linked to all kinds of conditions we know very well, right from diabetes, hypertension, ischemic heart disease, atheroma, various kinds of arthritis, COPD, asthma, and also various psychiatric conditions like depression and dementia. So that's the breadth of this toxin called reactive oxygen species. Is that all right? So that's, if you like, is my take-home message for you. I'll just go back to a bit about why I'm talking to you. I've been a doctor now for how long? 36 years now. And I'm fully expecting to carry on in the NHS full time for 50 years. So I got another 15 odd years to go. Just casting my mind back onto my early medical days, I was mainly taught by senior nurses. It was rare for us to get taught by doctors or psychiatrists. So I've been, like I said, I've been a doctor for 36 years, of which 34 years have been in psychiatry, and I've practiced as a specialist for 25 years now. And this has essentially involved adult psychiatry, old age psychiatry, and psychiatric rehabilitation. At the moment, my main job is looking after elderly people, particularly vanishingly rare. Vanishingly rare.
Okay. Thank you.
Can I just finish? How long have I got again? How much time have I got now?
More than 30 minutes. You have already finished 30 minutes, doctor.
I'm out of time, am I? Okay.
Yes.
I mean, I think the one other thing I would like to, particularly for the nurse academics, I think there's quite a lot of nurse academics in the audience. Just be suspicious of experts. Be suspicious of publications. You know that the 3 big publications had to be retracted because of possible data falsification. Even before COVID, we knew that quite a lot of our so-called evidence base was created by articles where we could not guarantee data integrity. Okay. It is helpful to just think about these experts in terms of conflicts of interest, and there are most if not all the worldwide experts on COVID, on vaccination, all that have major conflicts of interest, which they don't talk about. They also have grant income, and they, you know, bit like the unfortunately, bit like the global warming, climate change issue. If you are getting grant income to prove that global warming takes place, you are much more liable to follow that theme. Otherwise, you won't get any extra money. Similar to that, in terms of COVID, in terms of developing new drugs, there's a huge amount of conflict of interest. For example, our Chief Scientific Officer, Patrick Vallance, as you well know, has £600,000, which is kind of like $800,000 invested in one of the vaccine producing companies. He doesn't disclose that, but he does. Okay. So academics need to be really suspicious. You need to learn critical appraisal. You need to learn the dark arts of digging around about certain authors to find out what they're up to and what their actual financial motivations are. Otherwise, you're going to get lost in the process. So that's a big lesson I've learned from this whole episode, that people are not what they seem to be in terms of not disclosing conflict of interest. Valence should, each and every time he comes on television for a briefing, should, if he is talking about vaccines, should be saying, look, you do realize I've got shares in I think it was Pfizer, wasn't it? Or Johnson & Johnson, one of those two. So he's actually supporting a vaccine which is not from Britain, okay, which causes even more problems. If he had shares in AstraZeneca, I would be okay about that. But the fact that he has big shares, a very rich man, big shares in an American company, makes me choke, unfortunately. Okay, so that's my parting comment. I'm sorry to be controversial, but I'm here to speak the truth.
Yeah.
And please look at my slides. They are self-explanatory. I have put in a lot of references at the end of the slides. You're welcome to check them out and find out for yourself.
I just want your email address.
Is that not at the top of my slides? I think my email address, or right at the bottom.
I didn't see it.
Right at the bottom, the last bit, I think I put in my email.
I cannot, you have to share your slide. I cannot get it.
All right. Alice, who I call Alice, my dearest, she will share the slides with all of you.
Yeah, I will. We will do that. We will do that.
Okay. Thank you very much.
Thank you.
Thank you.
Thank you, everyone. So if no questions, can we go for a 10 minutes break? 10 minutes.
I like to present a question about your opinion. I am pediatrician. My name is Berines. I am pediatrician.
All right. Hello.
Yeah, and it is very important for the pediatrician for in the pandemic of COVID-2, the fact that children are course disease mild, and they are really infectious and really contagious.
Exactly.
So most of pediatricians have studied the situation, and someone have said that the revision is the less number of angiotensin enzyme in the epithelium of respiratory mucosa, but the children are less number of this receptor.
Okay.
But it is very, very curious that the respiratory functional of children are much lesser than an adult. Well,
sure. So there's number of explanations for that. Actually, there is evidence-based explanations for that. The first one is the respiratory epithelium appears to be a lot more robust in terms of this stuff called IgA in children. So that's number one. Number two is their innate immune system appears to be a lot more active, so they can fight the virus at an early stage. We were worried about endothelial disease, and in particular this syndrome called Kawasaki's syndrome, but that didn't appear to be a big feature of the first wave. But obviously it is possible that in the subsequent waves the virus will mutate and will try and beat the IgA system and the endothelial protection given to children. So I wouldn't take it for granted that the children are safe in the future waves. There's 2 other waves coming, as you know, and we are particularly worried about the third wave, not the second wave. The third wave gives enough time for the virus to mutate, and because the virus has already colonized most elderly, all of the elderly and most of the adults, the virus will be looking to mutate towards children because they are the group which the virus hasn't invaded so far. Don't be surprised if Kawasaki makes a show come February, March, to be honest.
One moment, please. I have not presented till my question because in the last week, a team of researchers here in Spain has found that the triple vaccine, that is DTP, diphtheria, tetanus, pertussis, have 4 epitopes similar to COVID-2. And so they raise the possibility that the immunity for the contagion of a less severe disease in children could be based on this vaccination. This is very important because if this is real, if this research is proved, is confirmed, perhaps the vaccination with DTP for adult people would be very efficient. Which is your opinion?
Yeah, my opinion is a similar case has been made for the BCG vaccination.
No.
As you know.
No.
And yes, it has. In the areas around the world where BCG vaccination is still carried out,
yes,
they appear to have less COVID infection rates and infection fatality rates as well. I have published about the prospect of giving triple vaccination, either DPT or BCG, to prevent dementia. Okay, so these thoughts are circulating at the moment, saying that repurposed polyvalent vaccines might have benefit in terms of protecting from SARS-CoV-2 plus other viruses, because obviously in dementia, what the idea is that in both this kind of infections and dementia, the idea is to upregulate the immune mechanism so that the immune robustness is better after having one of these polyvalent, which is multiple vaccinations given at the same time. So that is promising. It needs both the BCG stuff and the DPT stuff needs replicating in a multi-center trial. But there are, again, same problem, I'm afraid. There's no money in it. There's no money to prove that DPT or BCG is effective in modifying the response of COVID-19 and COVID-21. There's a lot more money for brand new vaccination regimes. Okay, it's a very, very materialistic, very globalized market. There's a lot of money to be made out of COVID-19. We should never forget that. And all the kind of potential kind of pathways which involves repurposing previous medications and vaccinations will not be properly researched, I fear.
But the problem of BCG production, the problem of BCG production is very different from the production of diphtheria, tetanus vaccine, because it's more difficult. So, but what?
Well, actually, isn't the Germans, the Kaiser?
One moment.
Yeah,
don't answer me because I pose my question, please.
Yeah.
So, if the possibility to have a production of antibodies from DTP, we could start immediately with any need of human assays, and very and most cheap than the Oxford vaccine, Moderna vaccine, or Chinese vaccine. This is a question I present to you for the reflection. Thank you.
I think Spain might do it. but I cannot imagine the States and Britain and the kind of English-speaking countries doing it, because they are much more financialized and looking to make profits out of treating COVID-19. The Russians are actively looking at BCG vaccination. And I think the Germans are developing a new variant of the BCG vaccine.
Yes,
And
yes,
they
I
are
know.
looking at, along with India, I think they have a collaboration with India, setting up a new BCG vaccine, which probably will be tested in India. Well, it is being tested in India at the moment for prevention of COVID-19. So these things will happen in some countries, but a genuine WHO randomized study, same as what they have done for remdesivir, it's unlikely, sadly.
Okay.
I'm trying to keep to time. So is that all right? If that's okay, I shall leave you.
Any more questions for Dr. Prasanna? If not, we can go for a break for 10 minutes.
Thank you very much.
Thank you, Dr. Prasanna. It was a wonderful talk.
Thank you.
Thank you. So we'll meet again at 4:25.
Are you still there?
Yes.
Is that Alice?
Oh no, this is not Alice, it's Elvesa. I think they are in break.
Then break. I was going to apologize for the gentleman who I interrupted. I was meaning to cut short my talk. That's why, just to allow you to have the break. So please pass on my apologies to him. I didn't
Who
mean
is
to
that
leave.
guy? Breshna?
The chap from
Breshna?
Spain. From Spain, yeah.
Ah, from Spain is Juan. Dr.
Yeah, yeah.
Juan Brenes.
Please apologize, but the reason was I wanted to cut short my my talk and to give you a break. So that's why.
But I think you still can talk to him because I think he's still there, no? Can
Is
you
he there?
see him? Yeah. By the way, I'm Elvesa. I'm the one who is asking for your email. I want
All
to
right.
invite you to be one of my speaker too.
Oh,
Do you
right,
have-
right.
Yes.
So can you write it down just now? I'll let you know.
Yeah, I just wrote it. I need your answer.
Oh, I see. Yes, of course. I don't charge anything. There's no charge, and Zoom meetings are completely free. I suppose the reason I do this is to publicize the NHS and also my own trust organization, because we want to be a national player, I suppose. But that's the reason I do that. I'm not an academic. I'm a clinician, so I can be incredibly suspicious of academics and experts because they haven't done us justice during the first
That's why I
wave.
was interested to
We have
talk
had
to
a really difficult time as a bunch of doctors and nurses. And something I didn't tell people right at the beginning, we had guidance saying, do not at any cost use steroids, and do not ever use steroids with these patients. And of course, that was completely the wrong advice, as we found out. Most clinicians would have loved to have tried steroids at an early stage to prevent ventilation. So they have failed us. WHO has failed us because if you remember right at the start of the pandemic, they were discouraging Chinese people to fly. Sorry, they were discouraging stopping flights from China. They said there's no reason to do that. It's economically harmful, although they are the World Health Organization, nothing to do. It's not the World Economic Organization, but they stopped people from blocking travel from China, which was wrong. They were against masking, which was wrong. And they helped cover up what went wrong in China, because we would have wanted to know honestly what went wrong in China. We know lots of things went wrong there, and lots of things went wrong in Italy. But at least the Italians and the Spanish were honest about what was going wrong, so that if people who wanted to listen could listen. And of course, being completely arrogant, Britain and America, they didn't listen to what the Italian doctors were saying and the Spanish doctors were saying. And the ones who listened had better outcomes, actually. So there's, what can I say?
I
As
understand.
clinicians, both nurses and doctors have been incredibly let down, and poor nurses and doctors in ITU didn't get enough PPE, as you know. We weren't advised about the inoculum, and we could have used clothing items to cover our faces and mouth, and that would have done just as well.
I know. They don't allow you?
We weren't allowed to do that, we were said, you are professionals, you have to take the risk and go and treat patients. I mean, point blank, and that wasn't entirely right to my mind. I think because as you know, lots of people contracted the disease, some people died, and that could have been prevented. So the public health, civil servant doctors haven't done very good by us. That's the reality of it. The experts haven't done very well by us. I think we should have been given the freedom to do our best and try whatever treatments we wanted to try. But the NHS is not like that. It's a very diktat-driven service, and we are not allowed the freedom to try things when things are, and is it not Einstein who said the definition of insanity is trying to do the same thing over and over and over again, despite evidence that it doesn't work? I mean, that's what happened. That's the reality of it. And yeah, I think I'm kind of got over it, but I think there are a lot of very bitter NHS staff working at the core phase even now.
But that right now for the second wave, what are your preparation? Do you have any preparation?
No, basically steroids.
Okay.
That's the only thing which appears to work. One of the big controversies we are facing up to at the moment is people in care homes and elderly people. They don't do very well if they get admitted to hospital with COVID.
Yeah.
And I and a number of us wonder whether we should give them a big bolus loading dose of vitamin D, followed by dexamethasone for 5 days, right at the beginning, because there's no earthly reason why that should happen in hospital. That can happen at home. It can happen in a care home. As far as we know, a vitamin D bolus can be given by mouth as well as by injection. So there's no issues about bioavailability, particularly if you give it with vitamin K. So like I said, I look after people in care homes, and I personally would prefer rapid bolus of vitamin D, K2, probably zinc, and then dexamethasone. Those would be my standard way of doing things.
That's for all the patients there, for the old people?
Yes, you're right. I mean, I wonder whether everyone in care home should get a fairly big dose of vitamin D and zinc. Yeah, sure. Automatically. Yeah.
Okay.
And whether doctors should be given...
Regardless of their comorbidity?
Exactly, yeah. There's no dangers of high dose vitamin D. We are careful about renal function, but the evidence has been that people who are really deficient in vitamin D, if you give a bolus, it doesn't cause problems in the kidney. So, there's all this kind of negative hype and a very bad press for vitamin D for no reason, for no reason whatsoever. And I know that something really strange is happening. I think it's all to do with money and to do with expanding the medical allopathic model. And quite a lot of us are feeling quite dispirited how money has entered this whole pandemic, really.
So right now you are using that kind of prophylactic treatment.
Some of us are. Some of us are. It's very frowned upon, but I know I got friends who are GPs who are doing exactly that, giving high dose vitamin D, zinc, vitamin K, and have dexamethasone ready if they become poorly. So that's the the GP I'm friends with. That's his way of doing things. He hates to send people to hospital, and he very much sympathized with me for having to section someone who subsequently died. So I didn't know. I hadn't really fully appreciated when I sectioned that patient that there was going to be COVID in the ward. There wasn't when I sectioned her and sent her into hospital, but within a week there was COVID and she contracted it and died. So that will rest on me for the foreseeable, isn't it? At the end of the day, because I knew I had serious misgivings, and I think I would have been in trouble if I didn't section, to be honest, because things would have got worse and someone else would have come and sectioned her anyway, But there you are. These are the things doctors have to live with afterwards.
Just for example,
I feel really sorry for anesthesiologists who know that they kill people in large amounts, and it's difficult. It's not easy, not easy.
But when I share this information to my colleague, will you be able
which
to?
Which country do you come from?
From Canada.
Oh,
Canada.
right. Gosh, yeah. Whereabouts?
Yeah. Pardon?
Whereabouts?
Pardon?
Which city? Montreal.
Montreal.
Right.
Yes. Have you been
that
here?
Was no. Just that. Are you a anesthetic nurse or are you a academic?
Before, yes, I was an anesthetic nurse before. Yeah.
Right.
Yeah.
There's this famous comment by a Canadian anesthesiologist. Do you remember a chap called Cameron Kyle Siddell from New York? He, rather than publishing through the normal medical channels, he went on YouTube. And I saw his first YouTube clip right as it came out, saying, look, we are making big mistakes. Lots of people are dying. We don't understand this condition. It's not straightforward ARDS. There's something else happening. There's a diffusion problem. It feels like high altitude sickness. And of course it was because of pulmonary hypertension due to endothelial damage. And he said, we are jumping into ventilation far too early. We are using far too high volumes and PEEP. And he said, we've got to stop doing this. And as you'd expect, this YouTube clip went viral. And he met up with 4 pals of his in critical care, and that included an anesthesiologist from Canada.
Oh, yeah.
And the famous comment she made halfway through one session was, don't do dumb shit, meaning, and that still, most of us remember that. When she said, don't do dumb shit. And a lot of people were doing dumb shit at the time, you know. So that's a bit of Canadian, Canadian comment, which I remember still. And that was back in March, I think. When,
so, but I was just thinking.
I mean, I'm surprised Cam didn't get sacked for that. Cam Kyle Siddell, for going on to YouTube. He didn't. I think he came fairly close to it, but you know, because it made lots of anesthetic specialists in the States very angry that he blew the whistle, if you like, that they were killing people, you know. So I think the Canadians were much more circumspect by the sounds of what she was saying, that they were being a lot more careful about trying nasal cannulation first and CPAP. So they weren't jumping straight into ventilation, whereas the New York ones and Britain, they were jumping into ventilation very early. And I'm afraid lots of people died who shouldn't have died.
Because, you know, jumping immediately to intubation, first of all, there's not enough machine to provide the patient. So that's why you have to do it, you know. And I don't know if you have that problem too.
They made a big fuss about not having enough ventilators.
Yeah.
But actually, in Britain, in Canada, in the States, we never, ever ran out of ventilators, ever. You know, that was a complete fake news. And there was this big attempt. I don't particularly care for Trump, but to be fair to Trump, he made every effort to get lots of ventilators into New York. And they're still there in their packing, in their wrapping bags and in their boxes. They were never used. You know, and I think what happened was people went on ventilation early. They couldn't take them off ventilators. So there were, in a funny sense, a lot more people would have died if they had lots of ventilators. I'm afraid. All right. So because of the so-called shortage of ventilators, a lot of people were spared of getting ventilation. You know, they had no choice but to give nasal cannulation. And I think that saved quite a lot of lives in retrospect, you know, in a funny way. You know, I think if they had lots of ventilators, a lot more people would have died, even more than what we experienced, sadly. The nurse, what do you call it? The respiratory attendants?
Respiratory therapists.
RTs, yeah.
Yeah, RTs.
they were in a really invidious position because they were being ordered by the anesthesiologist to pump up the volume, if you like, you know. And I don't know that would have put a lot of pressure on them. I feel for them because they were expected to take orders from the critical care specialists, orders which were completely wrong. So
yeah.
So that maybe that's another lesson for RTs to say, no, I'm not going to do that. Sorry, you can do it yourself. You know, so maybe that's another lesson to learn from all this.
Yeah. Fortunately, yes. They're making. I think Dr. Juan Brents is there. If you want to talk to her.
Juan, are you there?
No, sorry to interrupt you, Dr. Prasanna. As we are running out of time, can we go for the next talk? Sorry for that.
All right. Can you please apologize for that Spanish doctor who I interrupted? The reason being, of course, that I wanted to cut my talk short. So please apologize.
Please. I am very pleased to hear you because your talk has been extraordinary with a richness of content that for many aspects unknown for me. Excuse me and apologize.
I wish to apologize to you.
Yes. But as pediatrician, as I am I am very interested in the behavior of children with the COVID infection. So and I was really astonished because the new I can't precise if there is a good new or fake, but I think is a good new because the possibility to vaccinate it to coronavirus with diphtheria DTP, diphtheria tetanus pertussis, is an easy possibility, and I beg you with your experience to give a reflection on the subject. This was my intention.
I shall dig up the relevant literature about DPT in SARS-CoV-2. I will do that. I know quite a lot about BCG, but I don't know enough about DPT. Its efficacy in preventing COVID. So I shall. That's one of my big learning points from today. That I will look it up, and I will learn more about it. I sincerely hope that there will be a big trial, because for preventing COVID, it will have to be a massive trial, big numbers. Because in terms of treating COVID, the numbers can be relatively small, like a few thousands, but preventing COVID, it will have to be a much bigger number to be put into a randomized study. So I will look it up. That's a bit, I'm a bit blindsided on. I don't know enough about it.
Maybe we can share the work and trying to.
Sure, yeah.
All right?
Sure.
Yeah.
I can assure you that only the information about the Oxford vaccine is deserve your talk. Very good, very interesting. Your information.
Okay. Yeah.
I hope I don't get into trouble for saying the things I did.
Okay.
No, that's true. It's very interesting, and I learn a lot from what you say.
Yes,
Thank you so much. Thank you.
Thank you very much. Thanks.
But don't forget your email.